So I would like to introduce our next speaker, Dr. John Hood. And he is the founder, CEO, and executive chairman of a company based in San Diego named Endeavor BioMedicines. And you see an email on your screen right now. That is how you get a hold of Dr. Hood. If you have any questions on what he's going to talk about, which is really critical. He's a 20-year veteran of the San Diego life science community, and he's participated in the founding and leadership of several San Diego biotechs. Let's see, I really would rather just let him talk. He's amazing, but he's going to talk about something today that none of us know enough about, which is advances in precision medicine, next generation sequencing, testing, and breaking barriers with clinical trials. There's so much that the general public doesn't understand about genomic testing and biomarkers and next generation sequencing and comprehensive genomic, and how you identify in solid tumors the molecular makeup basically of that actual tumor, and how targeted therapy is really using therapies to target those biomarkers in that particular solid tumor. And that's something all of us need to think about and learn more about, because that is the way science is moving. So Dr. John Hood, I would like to turn this over to you. Are you ready?
I am. Thank you so much for the introduction. It was really warm and nice. And thanks for everyone coming on today. It's always a pleasure to meet you. And one of the things when I'm talking to patients is it's incredibly important to be your own advocate. And by being here today, I can see that you're all doing that. And that's insanely impressive. And thank you. I'm going to see if I can share screen really quick. I believe this is it.
Thank you.
All right. And there we go. Everyone sees it okay?
Yes.
Oh, wonderful. So I'm going to talk a little bit about precision medicine, NGS testing, and what you can do by getting into a clinical trial. And I'll talk a little bit about the clinical trial that Endeavor's running in particular. And you probably already know a fair amount about NGS, but just to make sure everyone's on the same page, I'll do a couple quick slides on that and explain why we're doing it and where I believe the treatment of cancer is going. So in the past, traditional cancer treatments, largely chemotherapy, it's non-specific in that it stops the ability of any cell to grow and divide, whether it's a cancer cell or a normal cell. It does have some level of specificity in that certain regimens work best for certain types of cancer, but overall, it's just targeting proliferating cells that are growing, and that gives severe side effects, and there's a pretty significant risk of cancer reemerging. Because healthy and cancer cells alike are both targeted, it becomes very challenging to get to a complete kill of the cancer, which may be more resistant. In contrast, targeted therapies. These are therapies that specifically target the mutated proteins that drive the cancer to grow and spread. And different cancers and even different patients with the same cancer can have very different mutated proteins that are driving or causing their cancer. And this is to go back to one of the things that Alyssa said earlier on. She had this hope that we will develop a cure for cancer. And I don't think we'll develop a cure for cancer, but we're developing cures for specific cancers by going after what it treats. Back in the 90s, Brian Drucker, Novartis, they showed that by inhibiting the cause of chronic myeloid leukemia, patients were living very long lives. You actually were having tremendous clinical benefit by going after the root cause of the disease. We're trying to do that in more and more cancers now, and it's not just through targeted therapies. There's also things like immuno-oncology that can help certain patients. And we're actually creating subsets of patients for which we have very significant clinical benefits. We're able to significantly improve their lives. So for individuals with a single mutated protein that's really driving their cancer, inhibiting that with a targeted therapy can have profound clinical benefits with fewer side effects. And the key thing is testing is needed that's done by other companies to reveal which mutated proteins are in an individual patient's tumor. And that's something you can work through with your oncologist. There's a number of companies that do this. More and more states are actually requiring insurance to pay for it. It can be part of your standard cancer regimen. And one of the other things is a number of the tests can be done now just with a simple blood draw. You no longer need an actual sample of the tumor. So phlebotomy is sufficient. They throw it into the lavender top tube, just like they do on probably every visit for something else. It's just one more tube. What you get by doing that, and let me actually shrink my screen so I can see my own slide. By getting NGS or next generation sequencing, you can actually get smarter about your cancer. Your oncologist can get smarter and get to a better therapy. They understand the driving mutations. As I said, there's lots of companies, wherever you are, there's people that will do that. And the patients with fewer types of mutated proteins are likely to respond better to a targeted therapy because their tumor is critically dependent on that protein. And by inhibiting it, you can actually rip out cancer at its root. Okay, I'm going to tell you, this is an example. This is the molecule we're working on, ENV101. There's an ongoing clinical trial with this agent right now. Taletagib is its formal name. 101's a lot easier to say, so that's what you're going to hear me say over and over. This is a molecule that was originally being developed by Eli Lilly, specifically for basal cell carcinoma. They put it through a lot of patients already, close to 200, many with cancer and some healthy volunteers. So the molecule that's being evaluated today has a lot of safety data. We understand what the molecule's doing. It's well along in the clinical trial paradigm. Now, when Eli Lilly first introduced that molecule, NGS was not yet common. So they could only go after basal cell carcinoma, in which case 70% of BCC is driven by mutations in this pathway. What we can do today and what we in-licensed it for is to use the same molecule on the 2.5% of patients without BCC, but still have the same mutation that's really driving it. So that can be a fair number. In medulloblastoma, it's roughly 25% of the patients. It's also seen with a decent frequency in neuroblastoma as well, and at a much lower level frequency in glioblastoma. So if you do have that mutation, we know from previous data that this molecule has an opportunity to be very, very effective. The specific mutation we're looking for is a patch 1 loss of function mutation, and that activates this pathway, the hedgehog pathway. The hedgehog pathway typically is very active during embryonic development, not that active in adults. The only times it becomes active in adults is in wound healing, or for the most part active is in wound healing and oncogenesis. So this becomes very problematic. This becomes something you can actually inhibit that is unlikely to be active in an adult patient. So it creates a ripe opportunity to have a significant treatment benefit without significant side effects. The other thing that's been noted is patients with patch 1 loss of function often don't have other common driver mutations. This is really important as well because that means inhibition of pathway, because this is frequently the only driver mutation can have profound clinical benefit for the patients. We do have, as I said, Lilly originally was running this with basal cell carcinoma. There was one patient that was treated with stage 4 medulloblastoma. And in that one patient, we're very happy to say they had a complete response. So the tumor completely shrank. So if you have the right background mutation, there's a good chance that this could be effective for you. The clinical trial we currently have going on, you can find it on clinicaltrials.gov, but it's far more efficient just to email us. We can put you in touch with whatever facility is closest to determine if you have the right mutation and see if you're eligible for the trial. You have to be more than 18 years of age. There are some patients who will take under 18, but there's specific requirements on bone, because the one thing it doesn't happen post-embryonically is it's important for bone plate fusion. So typically under the age of 13, it would be much more problematic. and you have to have patch 1 loss of function confirmed via NGS testing. Your physician can help arrange NGS testing if you don't already have it, and failed current standard of care or refused standard of care. Those are really the main things we're looking for. We're looking for patients who can benefit, i.e. they have the right mutation and they've exhausted other standard of care, so we're not having to withhold something that could otherwise benefit. And a question we're frequently asked about is there's a lot of barriers to a clinical trial. Your clinical trial site might not be your closest hospital. So in things like travel costs, we can provide a travel concierge that reimburses these costs. We try to help you. If there's often, if the sites are very far away, there's often a right in time or just in time sites. We can open up a clinical trial site just for you. And that may only take as long as 1 to 2 weeks. Insurance, you don't have to have insurance. We'll pay for that. We've actually had some concerns about confidentiality in the past, and I just want to confirm to everyone that that's strongly maintained. We don't know your name. We don't know your identity. For us, the data is linked to a number, and we're looking to make sure you're well taken care of, but we don't know you. Stigma, you're not a guinea pig. We care. All we're trying to do is help you live longer and feel better. So if you actually have the right background, we would love to bring you in. Other issues sometimes can be more difficult, but if you have an underlying concern like child care or time off, just reach out, and if we can do something to help, we will. And we also, even if you don't have the mutation we're working on, I encourage you to go to some of the patient matching services like XCures or Leal Health, and they can be a cancer Sherpa for you, guiding you to what could be the best care, the care that's specialized and tailored just for you, and identifying the clinical trial sites closest to you to be able to give it. And once again, if you have any questions, if there's anything we can potentially do to help you, please reach out. You've got our phone number and email on the screen, and I'm sure that End Brain Cancer would be happy to send it to you as well. All right, I'm going to stop the share and open it up for questions.
I would like to say thank you, Dr. Hood, for addressing this topic, but also addressing the barriers to clinical trials. Those are real, and your company obviously understands that. Thank you so much for bringing that up and addressing it. One of the things I'm curious about is can you talk more about the individual clinical trials that your company is able to set up wherever the person is in the United States?
Yeah. So that goes into it's a really interesting concept. The other speakers may be able to speak to it as well. I don't think it used to happen. They're called right in time or just in time sites. And in that case, if you're you're not right next to a major comprehensive cancer center like Sloan Kettering or MD Anderson, et cetera, but you want to be a participant in the trial and you qualify for the trial, there's hundreds of sites in the nation right now that use one centralized review committee that we're already past. So we can open up that site. We've opened one up in as few as 8 days. So we spec out the nurses, the oncologists there, they qualify, they understand the drug, they're open, because we've already gone through the review board that would allow us to go through. They use it centralized, and that's been incredibly useful. It's really saved us. We've had patients in other places have to travel literally hours to get to the clinical trial site, and I'm sorry, if you don't feel well, being in a car for 2 hours both ways is onerous, it's daunting. So this is a way we can hopefully get sites open that are much, much closer.
Thank you. That is amazing and encouraging. Does anyone else have a question for Dr. Hood? So I do have another question myself. Going back to liquid biopsies.
Yeah.
Okay, so that was, first of all, we're learning a lot about liquid biopsies ourselves at the End Brain Cancer Initiative. And And we're really excited about the opportunity potentially to know exactly what kind of brain tumor somebody has before surgery.
Yeah.
Sometimes that can happen with those liquid biopsies. But something you said was really interesting. Yes, we are all working on reimbursement for next generation sequencing testing, and we've had some success. We've gotten actually some through the Medicare, Medicaid system, as well as evolved through different health insurance companies. It's an ongoing piece of work that actually EBCI does on the behind the scenes. But you said something about liquid biopsies perhaps could actually be included, in your regular checkup or your regular, do you know what I'm trying to ask you?
Yeah, so it's because you can do it as a simple phlebotomy now and go into a lavender top tube. It's much easier to do it when you're seeing your oncologist. You just have to see an RN and they can send it out quickly and easily. And the reimbursement angle, I think it's going to take a while for the insurance companies to get through it, but the last I saw, we're up to 14 states that absolutely require insurance to pay for it. Good. Which is enormous, because there's a tremendous variability in cost. There's some that are under $1,000 now, and B. Anderson I think is $6,000. So getting that paid for is huge.
Wonderful. Anyone else have a question for Dr. Hood? Oh, I see Mary Lou, you have your hand up. Will you unmute yourself, please? Thank you.
Yes, thank you. I hope I'm going to be clear. So my son has a diffuse midline glioma. He's seeing his oncologist on Tuesday. Should he request a next generation sequencing?
I actually think everyone should request NGS,
Okay.
Because even if there's not a targeted therapy that's for you, a lot of times the NGS testing will help indicate what other therapies can potentially benefit. You can get guidance from that. So yes, I 100% think anyone should get it.
Once we have that, if he doesn't have a pitch 1, what kinds of things should he be looking at?
Well, I think that would be a great time to reach out to someone like XCures, and that's a service that doesn't cost anything. And they'll look at his background mutations and be a matchmaker for the best standard of care for your son.
How do you spell that?
XCures.
We can help you with that.
Thank you.
Yes.
Thank you.
We can actually, we can put you together with them, as well as we can actually upload your records as well to XCures. We have a contract with them to be able to do that to help patients.
It's such a great service that's been put in. It's so hard. One of the things I found most shocking was a local Illumina does all the gene sequencing. Their machines do. Their former CEO, Jay Fladley, went through his own experience with cancer about a decade ago. And even as the guy who runs the company that does the sequencing, he had trouble getting through the whole network and finding out what to do. So that's why organizations like Leal and XCures are so important.
Agreed. Thank you, Dr. Hood. Thank you so much for your talk today. Very enlightening. Thank you. And empowering.
Thank you. Thank you for all your time.
Of course.